Good morning, class. So today we are going to continue with the topic of bone and bone metabolism. So we'll be seeing today the theories of mineralization, the mechanism of mineralization and bone remodeling, about alveolar bone, and the clinical considerations of the same. So starting with the calcification theories, there are three theories for calcification of bone. First is the nucleation theory. Next is the booster or phosphatase theory. And next is the matrix recycle theory. Starting with the booster or phosphatase theory. According to this theory, there boosts the local calcium and phosphate ion product to a point where precipitation of the calcium and the phosphate occurs, and this happens by two mechanisms. There is effect of alkaline phosphatase and there is effect of ATPs. Effect of alkaline phosphatase. So what happens is hexose phosphate is converted into hexose and phosphate ions by the help of alkaline phosphatase enzyme. Now these phosphate ions which are released then combine with the calcium ions to form calcium phosphate, which is an amorphous form, and then later forms spontaneously into apatite crystals. So the favoring points for this theory are that cartilage from young rats, when it was incubated with solution containing calcium ions and organic phosphate, normal calcification took place. That is calcification in vitro. But the demerits which do not support this alkaline phosphatase theory are alkaline phosphatase in tissue, which does not is present in the tissues, which does not normally calcify. Then the enzyme inhibitors did not affect the phosphatase, inhibited calcification in vitro. The calcification in vitro was later found to occur in solution containing calcium ions and inorganic phosphate as well. Effect of ATP. Now ATP splits to form pyrophosphate, which enters the bone, and with the help of the enzyme pyrophosphatase, it produces phosphate ions. Now, White and Hess experiment showed that bone from which all enzymes had been destroyed or removed still possessed the property of splitting phosphate esters, suggesting the existence of certain substance which could split phosphate esters and increase the concentration of phosphate ions. So these are the points which are against this theory. Now, nucleation theory. According to this theory, there are three types of nucleation: homogeneous, heterogeneous, and secondary nucleation. The local increase in concentration of inorganic ions will permit sufficient number of ionic clusters and crystallite to form. This is called homogeneous nucleation. According to heterogeneous nucleation, the presence of nucleating substance will allow crystal formation to occur in the absence of local increase in the ionic concentration. So in heterogeneous nucleation, there is a presence of nucleating substance and a local increase in ionic concentration is not required, unlike the homogeneous nucleation. In secondary nucleation, the mineral phase particles arising from collision and fractures of crystals previously formed by heterogeneous nucleation causes the calcification. So this is secondary nucleation. Now, the process is called epistaxis, which is the seeding process. The substances act as seed to form calcification. The seeding substances are collagen, chondroitin sulfate, lipids, and non-collagenous molecules like phosphoproteins and proteoglycans. The seeding substances like collagen, it acts as a seeding agent as it helps in cross-banding of collagen responsible for mineralization. The phosphate may get attached to the amino acid serine in the collagen, where it attracts the calcium ions and thus becomes a nucleating center. So in calcium binds to the carboxyl groups, hence these groups induce seeding. So these are the collagen fibers. Phosphate attaches here, attracts the calcium, and this acts as a seeding agent and leads to the formation of hydroxyapatite crystals between the collagen fibers, and thus the calcification is happening. Chondroitin surface, most acidic substances in calcifying tissues favor attachment of calcium ions. Lipids. When lipids form a variety of tissues added to a solution of calcium phosphate, a precipitate forms consisting of apatite crystals largely and lipid to a less extent. Lipid could not be extracted from the precipitate unless the apatite was dissolved first, thereby suggesting some form of firm binding. The other non-collagenous molecules also help it act as a seeding agent. The last theory is the matrix vesicle theory. The matrix or the membrane vesicles arise from specialized area of the plasma membrane of osteoblast, odontoblast, cementoblast, and chondrocytes. Type 1 vesicles are round or oval in shape. They resemble lysosomes, contain acid phosphatase, aryl sulfatase, and break down glycosaminoglycans and proteoglycans. Type 2 vesicles are irregular in shape. They contain alkaline phosphatase, ATPase, and lipids. This is the matrix vesicle theory, in which this is the calcium binding site. An amorphous mineral attaches to the membrane, and a vesicle is formed around it. This is the vesicle formation. This is the mineral. Then the vesicle pinches off from the membrane and crystals start appearing inside the vesicle. So the crystalline mineral then grows in size, and finally the vesicle ruptures and the crystals are released, and hence the calcification takes place. So what's the mechanism of mineralization? Osteocalcin and sialoproteins, they bind extracellular calcium. This increases the local concentration of calcium ions. The increase in the concentration of calcium ions stimulates osteoblasts to secrete alkaline phosphatase, which increases the local concentration of phosphate ions. Further increase in the calcium ion concentration leads to osteoblast blast releasing the matrix vesicles like alkaline phosphatase and pyrophosphatase by exocytosis. This cleaves the phosphate ions from other molecules of matrix and accumulates the calcium. Increase in the isoelectric point leads to crystallization in the surrounding matrix vesicles. This initiates the matrix mineralization. What is bone remodeling? The process of bone resorption and bone formation takes place in bone remodeling. This is a picture which shows a new bone formation here. These are the osteoblasts. These are the osteocytes with their ruffled border, multinucleated cells in Hoschep's lacunae causing the bone resorption. This is the bone marrow consisting of the blood vessels. This is the endothelial lining of the vessel with RBCs in it. And so there's a new bone formation happening and there is a bone resorption happening. So this is called, there's a cutting cone and this is a filling cone. So what happens is the osteocytes cause bone resorptions in the Hoschep's lacunae. This is followed by the osteoblasts which come in that area and lead to bone deposition in the same area. And in doing so, a few of the osteocytes get entrapped in the bone and they're called osteocytes. They are found in the lacunae of the new bone formed. And the centered part is the Haversian canal. So this is the cutting cone and this is called a filling cone. And finally, a completely new osteon is formed. This is the remodeling cycle. Like I said, these are the precursor of the osteoclast. When activation takes place, they are in the quiescent phase. When activation takes place, they get activated and cause resorption in the area. This is the Hirschsprung's lacunae under the osteoclast. This is the resorption happening, and in the reversal phase, what happens is the osteoblast follow in the same area where the resorption has taken place, and they lead to the deposition of the new matrix and bone formation. Mineralization takes place, and these are the osteocytes which are entrapped while the new bone is formed, and these are the osteoblasts. So this helps, the formation and resorption helps in maintaining the balance. These are the reversal lines. Reversal lines are the wavy lines which appear, and they appear because of the process of resorption and bone formation happening in the area. Like I earlier showed, the osteocytes resorb in the area, which is followed by the osteoblasts following them and causing bone deposition in the area. So reversal line is nothing but it shows the activity of resorption and bone formation happening in the area. Factors affecting bone remodeling are activators of bone resorption are hormones such as parathyroid hormones, vitamin D, and thyroxine, and agents which causes bone resorption are prostaglandins, interleukins, factors like TGF, CSF, TNF, lymphotoxin, epidermal growth factor. The inhibitors of bone resorption are hormones like calcitonin and estrogen. And agents that cause inhibit bone resorption are gamma interferon. Activators of bone formation are hormones like vitamin D metabolites, insulin-like growth factor, estrogens, anabolic steroids, and thyroxine. And agents like insulin-like growth factor and prostaglandins are activators of bone formation. The hormones that inhibit bone formation are glucocorticoids, and the agents that inhibit bone formation are transforming growth factor. Now, regulation of osteoblast activity. Factors like parathyroid hormone, receptors on osteoblast are present of the same, and the persistent increased level of parathormone lead to increased osteoclast formation and hence bone resorption. Vitamin D3 stimulates the synthesis of osteocalcin and osteopontin by osteoblasts. This promotes calcium absorption from the intestine. It also promotes calcium absorption from the intestine. Growth hormone, it binds to membrane-bound growth hormone receptors on activated osteoblasts. Insulin, it targets the osteoblast, stimulates bone matrix formation and mineralization, and indirectly affects bone formation through stimulation of IGF-1 produced in the liver. Bone morphogenetic proteins. Their action is migration, aggregation, and proliferation of mesenchymal type cells and their differentiation in osteogenic cells. IGF-2 stimulates proliferation of osteoblast precursors. FGF increases the proliferation of osteoprogenitor cells and promotion of osteogenic differentiation. Glucocorticoids, it promotes the differentiation of osteoblasts and stimulate bone matrix formation. Prolonged treatment with glucocorticoids lead to bone loss attributed to increased PTH production in response to inhibitory effects of glucocorticoids on calcium absorption and depletion of osteogenic precursor cells. PDGF, it promotes osteogenesis. It's a potent mitogen for all cells of mesenchymal origin. Estrogen, it suppresses production of bone resorbing cytokine. Its deficiency leads to marked bone resorption. It prevents excessive bone loss before and after menopause by decreasing the lifespan of osteoclast. That is, it causes apoptosis of the osteoclast. It increases the production of TGF-beta by osteoblast, which stimulates the apoptosis of osteoclast. Vitamin D3 and PTH, they regulate the osteoclastic development. Calcitonin, It inhibits the proliferation and differentiation of osteoclast precursors, reduces the dimension of ruffled border and their dissociation into monocytic cells. Interleukin 1, 6, 8, 11, they enhance the osteoclast formation. Factors like IL-4, 10, 12, 13, and 18, they also limit the osteoclast formation. TNF-beta, tumor necrosis factor beta, it promotes the differentiation of osteoclast. Osteoclast inhibitory lectin, it is an inhibitor of osteoclast formation. TGF-beta and interferon gamma, they inhibit the proliferation and differentiation of committed precursors into mature osteoclasts. Biophosphonates, they have high affinity for hydroxyapatite, the ability to inhibit osteoclast bone formation. They are anti-bone resorbing agent, induce apoptosis of the osteoclast in vivo and also in vitro. Prostaglandins, it stimulates bone formation, exert local effect on osteoclasts and their precursors, often mediating the effect of growth factor and cytokines. Coming to the alveolar bone. Now, the function of the alveolar bone is it houses the roots of the teeth. It anchors the roots, that is the insertion of the Sharpie's fiber in the periodontal ligament. Movement of teeth for better occlusion, it helps with it. Absorb and distribute occlusal forces generated during tooth movement. It supplies vessels to the periodontal ligament. Houses and protects developing permanent teeth while supporting the primary teeth. This is the structure of the alveolar bone. As you can see here, this is the alveolar bone. These are the periodontal ligament fibers. And this is the tooth. This alveolar bone is the one surrounding the tooth. So the alveolar bone has two parts, the alveolar bone proper and the supporting alveolar bone. So the alveolar bone proper is again divided into lamellated bone and bundle bone, whereas the supporting alveolar bone is divided into cortical plates and the spongy bone. The spongy bone is again divided into type 1 and type 2. So alveolar bone proper is the one surrounding the periodontal ligament space, surrounding the tooth, and surrounding the alveolar bone proper is a supporting alveolar bone. The arrow here indicates the alveolar bone proper in maxilla and in mandible. So the parts are cribriform plate, the interdental septum, the canals of Zuckerland and Hirschfeld, the crest of the alveolar septa, and the lamina dura. Now, clinical considerations of the bone are bone vascularization, CT, and highly plastic enables high plasticity enables the orthodontist to move teeth without disrupting their relation to alveolar bone. Because bone is highly vascularized, it has a connective tissue which is highly vascularized. It helps in the orthodontic tooth movement. Increased functional forces lead to formation of new bone, whereas decreased functional forces lead to decrease in volume of the bone. Now, healing of fracture or extraction move. The embryonic bone which is formed first is replaced by the mature bone later. Visibility in radiographs lags 2 to 3 weeks behind the actual formation of bone. That is when the new bone is formed and the calcification happens. That is when it is viewed as a radiopacity in the radiograph. Endotoxins produced by gram-negative bacteria of plaque increases the cyclic AMP and thus the osteoclastic activity, which leads to bone resorption. The residual alveolar ridge resorption and mandible is downwards and outwards. And the ridge resorption, which happens with age in maxilla, is upwards and inwards. Resorption of bone following tooth loss leads to disuse atrophy, decreased blood supply in the region, localized inflammation or unfavorable prosthesis pressure also leads to resorption of the bone in the area. Loss of density of lamina dura leads to infection, inflammation, and resorption of the bony socket. Thank you. This was the end of bone tissue and bone metabolism.